Ladies and gentlemen, I am Dr. Ashok Kumar Batham, Chief Consultant, Dr. Batham Pharma Consultants. Under Dr. Batham's narratives, today I have chosen to make a reappraisal of anti-epileptic drugs for non-epileptic disorders with you. This, in fact, is a perfect case of reverse engineering, wherein anti-epileptic drugs that were primarily developed and marketed for the treatment of various types of epilepsies have been used therapeutically in indications outside epilepsy, and this has been a very successful experiment, and therefore I thought, let me make a quick appraisal of these indications outside epilepsy. And today I will focus on 6 of these plus one more interesting indication that has emerged in the recent past. So I'll talk to you about the applications of these drugs in cardiac arrhythmias, painful neuropathic conditions, trigeminal neuralgia, migraine, bipolar disorder, and generalized anxiety disorder. Cardiac arrhythmias are something similar to an epileptic seizure, wherein an abnormal focus discharges excessive impulses spontaneously and increases also the excitability of the cardiac muscle, and therefore, considering this as something similar to epilepsy, people tried phenytoin in the treatment of various arrhythmias, and then it got established that it is useful in the treatment of ventricular tachycardia and sudden episodes of atrial tachycardia not responding to other antiarrhythmics and or cardioversion. And therefore, this has become a drug of choice for treating arrhythmias caused by digitalis toxicity or digoxin toxicity, and for this purpose it is used intravenously. All these developments have led to the establishment of phenytoin sodium as a class 1B antiarrhythmic as described in most textbooks of pharmacology and medicine. The next indication I would love to talk to you today is neuropathic painful states. Because in neuropathic painful states, the chronic nerve injury is said to be associated with redistribution and alteration of sodium and calcium channels that predispose neurons in sensory pathways to fire spontaneously at inappropriately high frequencies from ectopic sites in a way very similar to epileptic hyperexcitability. So again, we have a situation which is similar to epileptic hyperexcitability, and therefore under these assumptions, anti-epileptic drugs have been tried in various neuropathic conditions, and it was assumed that these drugs with effects on voltage-gated sodium channels such as carbamazepine, oxcarbazepine, and lamotrigine have been found effective in treating neuropathic pain. Likewise, gabapentin, pregabalin also relieve neuropathic pain by selective binding to the calcium channel, subunit alpha 2A delta, that are overexpressed in sensory neurons after nerve injury. Thus, gabapentin, pregabalin, carbamazepine, oxcarbazepine, lamotrigine, and valproate have been found effective. So we got a half a dozen of the anti-epileptic drugs that could be used in the treatment of neuropathic pain. To say a few more words about these drugs, I would like to add that pregabalin has been approved by the US FDA in 2005 for the treatment of diabetic neuropathic pain, post-herpetic neuralgia, and neuropathic pain associated with spinal cord injury. Interestingly, this drug has also been found effective and therefore has been approved for the treatment of fibromyalgia, which is a psychosomatic condition with involvement of nerves and muscles. So this is very interesting because fibromyalgia generally does not respond to most of the conventional analgesics, etc. And specific therapies of this nature many times are required. However, one has to deal with the entire gamut of etiologies responsible for this psychosomatic disorder. Gabapentin is another drug which deserves a special mention because the clinical guidelines of European Federation of Neurological Societies in 2010 recommended gabapentin as a first-line treatment for diabetic neuropathy, post-herpetic neuralgia, and central neuropathic pain. This drug works either alone and much better in combination with other agents like morphine, oxycodone, nortriptyline, or venlafaxine. So it can be used, I am repeating, either alone or in combination with the drugs I mentioned just now. So gabapentin and pregabalin have emerged as very, very promising and established therapies for the treatment of painful neuropathic conditions in the recent past. Other drugs that could also be used are lamotrigine, and I already mentioned about phenytoin and valproate, etc. And very, very interestingly, phenytoin sodium cream has been used topically for the treatment of peripheral neuropathy and has been found useful. And similarly, it has also been used with success in the treatment of non-healing ulcers and wounds. Trigeminal neuralgia is an established indication of phenytoin as well as carbamazepine. So both of these drugs are used widely not only for trigeminal neuralgia but also other neuralgias like glossopharyngeal neuralgia, and most of the times carbamazepine is supposed to be the drug of choice, and if it is not tolerated well or is found ineffective, one may use phenytoin as a second-line drug therapy. Moving over to the next indication, I would like to talk to you about migraine, and for migraine prophylaxis, I would say, not for the treatment of an acute attack of migraine. Diavalproex as well as topiramate both have been approved by the regulatory authorities, and these drugs are very, very useful in people having repeated attacks of migraine. Gabapentin has also been tried in a number of clinical studies, but it has not been found to be effective, as shown by a Cochrane review published in 2013. The next indication is bipolar disorder, and here these drugs have been tried because of one or two reasons. Number one, bipolar disorder and epilepsy have some common features, like they both are episodic in nature, and neurophysiological studies have shown that in both the cases there is an associated kindling phenomena. Number two, understanding of the basic mechanisms of mood stabilizing action and clinical trials have led to the regulatory approval and use of the anti-epileptic drugs like carbamazepine, valproic acid, and lamotrigine in the treatment of bipolar disorder. I'll just quickly sum up the status of these drugs in therapy. Carbamazepine has been recommended by a number of bodies like Canadian Network for Mood and Anxiety Treatments and International Society for Bipolar Disorders recommended carbamazepine as an alternative to preferred agents for patients with bipolar major depression for prophylaxis of manic and mixed episodes. Number two, valproic acid. The efficacy of this drug has been established in clinical trials in patients meeting DSM-3 revised criteria for bipolar disorder hospitalized for acute mania. Lamotrigine has also been found effective and is therefore indicated for bipolar disorder to delay the time of occurrence of mood episodes like depression, mania, hypomania, and mixed episodes in patients over 18 years of age treated for acute mood episodes with the standard therapy. The target dose of lamotrigine is 200 mg per day, and recently topiramate has also been tried in a randomized controlled trial which suggested its benefits in the treatment of symptoms of borderline personality disorder. So that is about the status of anti-epileptic drugs in bipolar disorders. Recently, pregabalin has been tried in generalized anxiety disorder, and it has been found to be useful in the treatment of this condition, and it appears to have anxiolytic effects similar to those of benzodiazepines with less risk of severe cognitive and psychomotor impairment, development of tolerance, development of dependence, and a high abuse potential. So these shortcomings that we encountered with the use of benzodiazepines are not there with the use of pregabalin, and therefore one should feel very, very comfortable in prescribing pregabalin Lyrica in generalized anxiety disorder, because it is superior in terms of producing more consistent benefits on psychosomatic symptoms of anxiety as compared to benzodiazepines. It produces beneficial effects on sleep and sleep architecture as well, and therefore the World Federation of Biological Psychiatry recommends pregabalin as one of the several first-line agents for the treatment of generalized anxiety disorders. Lastly, I would love to talk to you about an interesting development that has happened in the last few years, and this is in relation to the application of topiramate either alone or in combination with phentermine in obesity as a weight loss drug. In fact, the weight loss has been found as a side effect of topiramate when it was used in epilepsy. We all know that this side effect has been now exploited in the treatment of obesity, and not only this, topiramate has been combined with phentermine with advantages, and this combination has been found to work very, very efficiently and has therefore been approved by the US FDA in 2012 under the brand name Qsymia. Of course, this drug has to be used under very, very careful conditions, and as a matter of fact, the approval has been subjected to its prescriptions under risk evaluation and mitigation strategy program of the US FDA, wherein the risks are evaluated in each individual patient, and on a named patient basis this drug is prescribed and used under very close supervision and monitoring. So, and as it is described as Schedule 4 controlled substance. So, because of the CNS side effects and abuse potential, this drug has to be used carefully. So, with this note, I would like to conclude that because of the overlapping pathophysiology of some disorders and corrective mechanisms of action of many anti-epileptic drugs, it has been responsible for the application of anti-epileptic drugs in clinical conditions outside epilepsy. I would reiterate that overlapping pathophysiology of some disorders and corrective mechanisms of action of many anti-epileptic drugs are evidently responsible for the applications of AEDs in clinical conditions outside epilepsy, and therefore a new anti-epileptic drug with additional approved indications in non-epileptic disorders is being considered to have a market potential 3 to 4 times larger than that of a drug having usefulness in epilepsy alone, and therefore the new drug candidates will be developed for both these sets of therapeutic applications, epilepsy and outside epilepsy. And with this, I would like to conclude by saying a big thank you for giving me a patient hearing. And if you like this presentation, please indicate the same and subscribe to my channel. Thank you very much indeed once again.